Okay, hopefully you've all had a good day. I guess as we'd say around here, it's been Boston. We've got a closing keynote with Emma, and with no further ado, I'm going to hand you straight over to Emma.
Thanks, Carl. Emma Robertson, 1st to the 10th, 1981, hospital number 6113857S for sugar. I'm Emma, and I am just a patient. And I guess I'm here to try to elaborate a little bit on why shared care records are so important to people like me. I was diagnosed with primary breast cancer in 2013 when I was 31 years old. I had a load of exciting treatments, IVF, surgery, chemotherapy, radiotherapy, more surgery, and then a lovely drug called tamoxifen, also known as tamoxibollocks. By Christmas of 2013, the brown paper folder that got put on the pile ready for my appointment with the oncologist was several inches thick. I diligently collected the letters that arrived and popped them in a box file in an attempt to collect my own record. Letters to my GP about what was happening to me, letters inviting me for appointments, letters explaining what would happen next, letters that were clearly cut and paste templates with my name, hospital number, and date of birth added in, almost an afterthought. My treatment for primary breast cancer felt very much like being on a conveyor belt with a lot of other people going through the same thing at the same time. There were lots of mistakes made, many of which I could have spotted and been able to correct had I been more actively involved in my own care and had access to my own medical information. That box file was a bit unwieldy for carting around. Back then, healthcare settings were very alien spaces to me. I didn't know which way around the gown should go, how long I was supposed to wait before I was seen, whether I should ask for help or wait quietly. And I actually waited for over an hour for my first appointment because I didn't want to upset the receptionists. When I finally asked, I found that my paperwork had been on the wrong pile, and if I'd waited much longer, actually, to mention it, everyone would have gone home for the day. So do be prepared to wait for hours if you need to, but don't assume they know you're waiting. During that initial chaotic year of treatment, marker clips were supposed to be inserted into my breast tissue before I had chemotherapy to shrink my cancer, and those clips weren't put in. The hospital apologised for the error, but it left me wondering why I hadn't been more aware of what I was supposed to happen in that procedure and how I hadn't known that something had been left off the list. Nobody realised that mistake had been made until after 6 rounds of chemotherapy had happened and my cancer had completely shrunk, and I was gowned up for the next procedure. I now actually have my chart access. Woohoo! So I wonder whether I would have seen that error at least in time to make some decisions about what to do next, so that the surprise didn't result in surgery being cancelled and rescheduled. With easy access to the right information, patients can become an active part of their own safeguarding checklists. Just as much as the wristbands, the repeated checking of name, date of birth, the multiple consent forms and the paperwork. Yes, patients might have more questions, but those questions could result in safer care. At the beginning of 2015, after a year on tamoxibollocks, I was feeling quite rough, and this was noticed at a routine follow-up appointment. Cue loads of scans, investigations, biopsies, and eventually my oncologist shared the news that my cancer had spread. It was now in my lungs and my liver and my bones. I was 33. I'm now 41, I think. So I've been a cancer patient for a long time. It was now in my lungs and my liver and my bones, and she was careful to explain that this meant it was treatable, but not curable. So I was immediately referred to my local palliative care team, who visited me in my home. They helped me to access some of the financial benefits that I was entitled to. My home was a boat, and I was a freelancer. So my income was not substantial or stable, neither was my home. Actually, those things haven't changed. And given my medical situation at the time, it was really important that the professionals I was dealing with knew that I lived on a boat and that my work was unreliable. I needed them to know details about my personal circumstances, like whether I was caring for children, whether I drove or had access to a car, what my employment situation was like, so that they could be sympathetic to my very individual needs. These details about my life helped them to think about how they might be able to support me if the treatment that they were giving me didn't work. Squeezing a hospital bed and oxygen tanks onto a narrowboat would have been challenging. When I was first diagnosed with my metastatic disease, I was put on an oral chemotherapy called capecitabine, and that worked really well, reducing all the cancery bits, making life start to seem more normal again. And then in the summer of 2016, I started to get chest infections. Treated with round after round of antibiotics by my GP, every hospital appointment seemed to be with a different person who didn't understand that I wasn't curable. It came to light that I had a pleural effusion that had steadily been increasing, so I spent some time in hospital having that fluid drained out of me. But battling with that lack of continuity of care at a time when I felt so unwell was really challenging, and having to fight for that fluid to be drained away was really hard. As a result of some of those experiences, I made the decision to move hospitals. I asked my old hospital for my patient records, that huge brown paper folder, and when I sat down and looked through that folder, a large amount of the printed forms that were in it hadn't even been filled in. I do quite a lot of patient advocacy and campaign work. I was the patient lead on the PRSB's nursing standards work. I'm a member of the patient advisory group for the Pan-London Transforming Cancer Services team, so a little bit of work with NHS England too sometimes. I've campaigned with MetUp UK, Just Treatment, Breast Cancer Now. I'm a member of Independent Cancer Patient Voices and several PPI groups, and I'm a trustee for a small grassroots cancer charity called Mission Remission. And when people ask me to introduce myself at the beginning of meetings, I usually say I am just a patient. I generally get kickback for that. Nobody is just a patient. We all know that patients' viewpoint is crucial to getting healthcare right. Healthcare should be collaborative. I should have a choice. And my consent does need to be informed. But there is tension there because I didn't get to choose to get cancer. And choosing not to engage with my healthcare would be choosing a very much shorter life. So in lots of ways, the NHS really has me over a barrel. I don't have a choice not to jump through their hoops if I want to stay alive. And when it comes to my care, I am most often reduced again to just being just a patient. Shared care records can help me feel much more in control of some of that. So they are very important on that front. As a stage 4 cancer patient, I really want my data to be shared and used. I want researchers to be able to know all about my cancer. I want student doctors and nurses to be able to sit in on my consultations, read my file, and hear my story. Yes, my experiences are unique to me, but if I share them, they can benefit other people who are having similar experiences. At the moment, I'm being kept well by a drug called palbociclib, which is a CDK4/6 inhibitor. It's a medication that wasn't available back on the NHS back in 2015. I actually accessed this drug through Pfizer's free trial, and I've been taking it since 2017. But NICE guidance says palbociclib should really be used as a first-line therapy for hormone-positive metastatic breast cancer, and I had already been treated with 2 lines of chemotherapy when I accessed it, which means for me, it's a third-line treatment. Maybe sharing my data could contribute to changing NICE guidance so that more women can access this drug after being pre-treated with other medications that might work better for their particular circumstances. I'm an open book, and data privacy kind of sounds like an excuse to not get stuff done. Data privacy gets in the way of knowing how many people are living with metastatic breast cancer here in the UK. Data privacy means that I have to shout my reasons for seeing the GP at the receptionist because she doesn't believe that I really need my appointment. Data privacy often means that I have to repeatedly tell people about the most traumatic periods of my life because they can't see that information about me on their screens. But I'm just one patient. And I know there are other points of view, and there are lots of situations where data privacy is really very important. And that's a really good example of why it's so important to keep patient input central to change and development in healthcare. We're also very different. Our circumstances are also very different. And it's one of the reasons why I'm very grateful for conferences like this putting patients up on stage. Another point I want to make about data is that it's very good at leading you down the wrong path. If we use risk factors to triage people, for example, non-smokers struggling to access lung cancer testing or screening, we risk dismissing and excluding from care people who could be successfully treated and cured. The week before last, I answered a call from my hospital and spoke to a lovely person who wanted to book me in for an ultrasound scan. I was a bit confused, but as a stage 4 cancer patient, this could have been for a number of reasons, so I asked why I needed this scan. I wasn't expecting to be booked for an ultrasound. I had a CT scan scheduled for a week's or so's time, but this could have been because my bones are thin. It could have been because I just had a smear test. It might be something to do with recent blood tests that had shown up something that needed to be checked out. Apparently, my GP had requested this scan over a year ago. The caller's voice actually sounded quite alarmed and embarrassed, and it had something to do with infection. I asked more questions, because if I had been living with infection for over a year, I should be aware of it, right? The person attempting to book me for the ultrasound was obviously a bit frustrated and rattled by my questioning, so she passed me to a colleague. Yes, this scan had been requested by my GP and was related to a bowel resection that I'd had in the 1990s. Big red flag. I have never had a bowel resection, and I was still at school in the 1990s. I asked the caller to please escalate this and also to call me back to let me know what had happened. This trivial and bizarre experience actually made me quite panicky and anxious. I was worried that information hadn't been passed on to me about my disease. Had bowel involvement shown up on a scan that was just not been shared with me? Had my recent smear test shown up something horrible and alarming? Basically, what terrifying new medical adventure was I about to be flung into? And then I connected the dots between this experience and previous appointments that I had attended with the bowel team that I thought had been related to some of my menopause treatment. I had queried and cancelled follow-up appointments because they didn't seem necessary. Had I been inadvertently cancelling somebody else's appointments? Kind of legitimate question. I called my breast cancer nurse, and she's actually specially dedicated to secondary metastatic breast cancer patients. She's been looking after me since 2017, and she's amazing. Thank goodness she knows her way around a digital record. Apparently, my hospital had changed their computer system supplier last year, and patient records have been shuffled across to a new system. Shouldn't have presented any problems at all, but I'm not sure I have ever heard of a faultless computer system, so of course there have been problems. I'm still waiting to find out exactly what happened, but it was timely that it happened, in time for me to talk about it here. It sounds like my digital records have been muddled up with somebody else's. I could have just gone to that ultrasound scan without asking any questions, but I really like to have a clear reason for spending yet more time in the hospital. Hopefully the other person hasn't experienced any serious health consequences if I have been cancelling their appointments, which is slightly terrifying thought. In nearly every episode, Dr. Gregory House says all patients lie. Of course we do, but so can your computers. And don't get me started on how many times he misdiagnoses and nearly kills his patients before he works out what the problem is. Digital records don't help patients unless they support medical professionals to use their judgment, to engage with patients, and to know that a one-size-fits-all approach is not appropriate for healthcare. A good record is not a substitute for good patient care. We can have lots of nuanced conversations about being led by patient need, but that need has to also be possible within the bounds of medical provision and care. Sometimes, when I think about shortcuts and simpler solutions in the context of my healthcare to save time or make life easier, it strikes me how closely an easier life for a patient could correspond to an easier life for that patient's care team. We've all been stuck on a self-service checkout that won't recognise the item you've just plonked on the scale. Delays recognising your items of shopping are not nearly so consequential as delays recognising symptoms of a serious health problem, though. But really, I'm here today to say to you that digital health records won't help anyone without a well-trained, energetic, enthusiastic, and curious healthcare workforce that knows how to use them. So my big plea is that we start to think about healthcare teams in a holistic way that includes admin and reception staff. Those front of house roles in medical spaces are crucial to good healthcare, and the people working in them do need to have some understanding of what patients are there for, as well as the simple fact that most of us really don't want to be there. It's very important that the people calling me to book me in for an ultrasound scan can answer me when I ask them why I need that scan. They're the people using those records. Imagine waiting for hours with the terror of cancer recurrence, spread or progression before a nurse can call you back and explain that a mistake has been made. And actually, my closing point really is I don't think we can talk about digital records and healthcare computer systems and not mention the post office scandal. People do make mistakes, computer systems do go wrong, but when mistakes do inevitably happen and when digital records are incorrect, refusing to check and take a second look, doubling down, insisting that no mistake can have occurred, that prevents errors from being corrected and it prevents the learning that should always come from making mistakes. Thank you.
I don't know how to follow that. Well done. I think if there's one thing that's resonated with me today, it's the sort of the patient stories and some of the clinical stories. I'm a techie, and while I think I know why I'm building this shared care record, I think sometimes it's good for us all to hear these stories, so we all know why we're here and what we're trying to achieve. So I'd like to give another round of applause to all the speakers that have appeared today, please. So tomorrow is going to be slightly more interactive, hopefully. So one of the sessions that Lee's going to lead is about sort of a call to arms and where we go next, setting up a bit of a charter. So have a think tonight, for those who are coming back and not wagging tomorrow. For those who are coming back, have a think tonight, the sort of things that you think we are missing, that we need to take forward collectively, the things that we want to pick up with NHS England colleagues, maybe some of the national sort of roles that they can play in supporting us. I know people have mentioned about GP Connect, we've discussed that. People have mentioned about the IG and how we share data, and I raised the NRL today, and a couple of people have already come to me and said, okay, so the NRL's great, Carl, but my IG agreement is within my patch. How do I share my record outside? So have a think, see what we can play back tomorrow. We've got some good speakers tomorrow, so I hope you're all going to be in attendance. A little bit of housekeeping. You need to bring your name badges back because we haven't got any more. And for all those who didn't register and snuck in without name badges, apparently there's a handful of you, can you let the front desk know so we can just record your name? They tell me, say it's about fire, but it's not really. We want to know if we can send you an email afterwards and say, you know, how you got on and that sort of thing. Not that we're going to bombard your email accounts. I'd like to say thank you genuinely on behalf of the organising committee and myself for you all coming today. Genuinely, thank you. And that's it. It's time for whatever you want to do next. Drink, beer, wine, lemonade, and I hope to see you all again in the morning. Thank you very much.